Hello, this is Dr. Wala. Today we're going to discuss a new grafting material for alveolar cleft reconstruction. At first, I'd like to introduce you the co-authors of this research at the Faculty of Dentistry, Cairo University. As you know, alveolar cleft patients suffer from an anterior maxillary bony defect which require reconstruction for closure of a nasal fistula supporting the alar base and reduction of adjacent teeth, allow eruption of canine, and feature implant placement when indicated. So, for reconstruction, anterior crest was a gold standard against which all other grafts are compared because of its osteogenicity, osteoinductivity, and osteoconductivity. However, the main drawback of anterior crest, or as a general autograft, is donor side morbidity. So the iliac crest graft was used here as a control because it is the gold standard. But despite being available, alternatives to autogenous bone grafting such as allograft carry the risk of disease transmission. Xenograft and alloblasts lack the osteogenic potential. In addition, there was reports that alloblasts such as hydroxyapatite and tricalcium phosphate may hinder tooth eruption through formation of dense cellular fibrous network at the grafted area. So, tissue engineering graft was found to be an innovative choice for various maxillofacial defect reconstructions. So, tissue engineering graft simply start by taking a biopsy from the patient, whatever bone marrow, adipose tissue, or bone biopsy, from which the cells, mesenchymal stem cells, are extracted and expanded in vitro, and then induced the osteogenic potential if the bony tissue to be used, and then loaded on a suitable scaffold, creating a construct to be grafted again in the defect. And this bypass the donor side morbidity and have osteoinduction and osteoconduction at the beginning. A surgery strategy was conducted to address tissue engineering grafts for alveolar cleft reconstruction, but only few reports were founded, with most of them were case reports, and only one clinical trial by Brother and Lural 2012. With different interventions and stem cell sources, scaffold types, and assessment tools. So, a randomized clinical trial was designed to ask these questions. If the tissue engineering constructs composed of bone marrow derived mesenchymal stem cells and osteogenically differentiated loaded on collagen scaffolds would give comparable bone results in terms of volume and density compared to the iliac crest bone graft or not. To answer these questions, 5 patients were retrieved for each group, and specific pre-surgical preparation were required for each group, especially the bone marrow samples to extract mesenchymal stem cells in vitro and blood sample for serum preparation for the tissue engineered group. The common preparation include clinical examination and history to exclude any systemic or syndromic disorder, orthodontic consultation for any required maxillary expansion before surgery, panoramic radiograph for any pathological tissue in the cleft site or supernumerary tooth that require extraction at least 3 weeks before surgery to allow for soft tissue healing. Also, laboratory investigations for assessment of the general condition and excluding any bone marrow disease. Then assuring the osteogenic potential with vencosa staining and alkaline phosphatase activity before scaffold loading. The bone marrow sample was collected aseptically by stab incision over the anterior superior iliac spine, and then the bone marrow sample was harvested and then transferred to be layered on lymphocyte separation medium according to the manufacturer instruction under aseptic conditions, and centrifuged to form the cell pellet that contains the mesenchymal stem cell fraction or mononuclear cell fraction at the bottom of the tube, which was then transferred to culture flasks in complete expansion medium and cultured under certain conditions. After which the cells were subcultured and induced the osteogenic potential before loading to the scaffold, and counted using a hemocytometer under inverted microscopy. and the collagen scaffold was then divided into equal layers onto which the cells were evenly distributed. On the day of surgical procedure, the construct was obtained from the incubator during patient preparation to be implanted in the defect. For the anterior iliac crest group, the iliac crest graft was subtracted from the surrounding bone to visualize the whole defect as it is present in the tissue engineer group, where the graft was radiolucent, to standardize the method of volumetric analysis in both groups. Here is a defect after 3D reconstruction. For registration and superimposition step, the 6 months postoperative 3D file was imported to the immediate postoperative CT file. Superimposition of the immediate and 6 months was performed, and then cutting planes were performed after series of point registration to superimpose both files to isolate the alveolar process from the surrounding bone. After which, the bone volume of each bony segment, 6 months bone volume and immediate bone volume of each alveolar process was performed, and the newly formed bone volume was calculated by subtraction the immediate from the 6 months post-operative one. For the density measurements, random areas were selected on the axial cuts of 6 months CT, and the average of 3 readings was taken. The mean density of all cuts was calculated and recorded. Here we can see the rounded mononuclear cells isolated from the bone marrow sample at day 0 of the primary culture. And after osteogenic induction, the bone nodules was seen under the inverted phase contrast microscopy, which was then confirmed by alkaline phosphatase activity and von Koza staining before loading on the scaffold. Healing went uneventful for all cases except for one patient in the iliac crest group where partial graft exposure occurred, and was managed by local antiseptic measures and systemic antibiotics. These photos to the right show mucosal healing 1 month post-operative. For the other group, healing also went uneventful for all cases except for one case where partial graft exposure 10 days post-operatively and managed as mentioned before till complete healing and eruption of canine occur. Here is graft consolidation occurred. This is immediate and 6 months post-operative, and the 3D of both of the same patient and same picture. For tissue engineering group, here we can see immediate post-operative showing the radiolucency of the graft and consolidation or bridging of the graft post-operatively, and this is the same photos 3D reconstruction immediate and 6 months showing bridging and eruption of canine. One of our earlier cases where this is immediate post-operative of the radiolucent graft and incomplete bone formation of the graft 6 months post-operative, and 1 year follow-up showed complete bridging of the defect. Regarding volumetric measurements at 6 months, there was no significant difference between both groups. Regarding bone density, the iliac crest graft was significantly higher than tissue engineer graft in bone density. Comparing the bone graft to the native bone, there was no significant difference between the iliac crest graft and the native bone, while the native bone of the tissue engineer graft was significantly higher than the graft. The result of this study was published on the Maxillofacial Surgery Journal 2021. I will leave the link below in the description box. From this study, we concluded that tissue engineered graft provide bone comparable to the iliac crest graft in bone volume, but the radiographic density of this graft was significantly lower at 6 months, but it increased in a time-dependent manner as shown in the 1 year follow-up radiograph. And tissue engineered construct composed of collagen and osteogenically differentiated bone marrow mesenchymal stem cell could be sufficient for unilateral alveolar cleft reconstruction. The authors recommend larger sample size with longer follow-up period to assess if the bone density of the tissue engineered graft would increase in a time-dependent manner as shown in this article, and if utilization of different scaffolds and different types and sources of mesenchymal stem cells would provide an appropriate scaffold and to formulate an optimum alveolar cleft grafting material. If you benefit of any of my content, please like and share with your friends. Thanks for watching.